But my focus in this presentation is what's next. What we have to do now. It's clear that some countries control the outbreak, but now what we have to do, that we can keep closing all the shops forever. We have to reopen as nothing happens. That will be my contribution also to the actual state of the art in the coronavirus management. Let me begin with the diagnosis of coronavirus and COVID-19 disease. Okay, here we are going to talk about today introduction and actual state of the COVID pandemic, review on symptoms and diagnosis of COVID-19, sorry, it says 16. First study, just to see one of the first patients that we were aware in Mindray, to see the follow-up. Another experience, very nice, because we were able to control the cytokines and to see the evolution of this cytokine storm in Wuhan. The third study, I did myself this study, that is the review of 92 patients with several status of mild, severe, and critical, to see how we can diagnose the different clinical status, but also how we can predict, and that will be, for me, also an important point for the future, how we can predict when the patient will become severe or will become critical. After, that is innovative, countries that did well, countries that maybe can do better, because I don't like to say they did wrong. And the 7th point, what's next? And I will introduce, today we were able to listen about the mental attitude to be better and to fight coronavirus. Today we are going to talk about also diet. That will be a surprise for you, because maybe you don't know that I have the title of Tibetan medicine that I got in the Mensekang University of Dalai Lama in Dharamsala, Himachal Pradesh. That will be a surprise for some of you. First, let me show you the COVID in the electronic microscope. And here a representation of the COVID in three-dimensional. This is a cartoon, but show us how is the COVID. Everybody have seen, because it's everywhere. But here, let me explain what is the actual situation. I am following up from the beginning of the outbreak, and really we can see here the number of deaths per day during all the outbreak. Of course, now the episode in China is practically disappeared because the scale is too big for the rest of the world. And China, here we can not even see the decrease of deaths in China that happened around March, at the beginning of March. What is clear is the increase of the deaths in the rest of the world is huge, but looks like, let me be optimistic, that countries like Mexico or South America or United States will not break this trend, but looks like we are in the top of the mountain going to initiate the decrease of this outbreak. Let me be optimistic. The facts are, in the end of February, were 3,127. The majority of China, some of them from Korea and Far East. In the end of February, were 40,000 cases. And in April, we estimate that the cumulative deaths will be about 225,000. As you can see, the growth of the deaths are exponential. That is an important slide to see how deadly is this virus. We can see here the H1N1 death rate, how many patients die from the one infected. And we have to consider that the H1N1 is one of the more deadly influenza virus. Remember the outbreak that I was in the WHO attending the meetings there. Now I go less. Now it's substituting me, Professor Gini, but I am representing ICS. I was representing ICSH in the WHO, and I remember this outbreak that people were really afraid because the death rate came from 0.1 to 0.5. That was huge, 5 times more. But now we are in front of 7 times more death rate than the H1N1. And that if you have a good healthcare system. You have enough protection for the healthcare professionals. Don't forget that in Italy, 10%, that they were not prepared for that, 10% of the healthcare professionals are infected. And in Spain, 20% of the healthcare professionals that are 20% of all the diagnosis cases in Spain are healthcare professionals. So they are not only patient, but also you can have not enough material to protect the healthcare professionals. And this death rate can go to, we will see today, some of the countries that are not doing as good as others, that they have death rates of 18%, 15%. That is amazing. Why? Because normally, if you have enough healthcare system, enough artificial ventilators, you can keep this 3.4. After, when you have collapsed your healthcare system, the death rate can increase to 10 or 15%. Here we can see the SARS, that was the previous coronavirus that affected, that the death rate was even double than the COVID-19. After is how many people get infected. You know, today we know that in the north of China, only one patient infected 87, but it was a big contagious guy. And the infection rate of the COVID is 3 times more than the influenza for some reasons, because there is no yet immunized people, and all the people are not, the majority of the people have not immunity for that, and the infection is 3 times. In the season when this coronavirus will be maybe come back, or in some countries, you know, we expect to have 3 times more cases than the influenza, together with increase of the death rate. Okay. Here, an important point will be also the differential diagnosis of the COVID.
Probably went into the
Sorry, Deepak, can you silence your microphone? Deepak Kumar, can you silence your microphone? Thank you. Yeah. Yes, the differential diagnosis, this is important because what we have to consider now in this outbreak is quite clear. But what will happen in the next outbreak when the countries now, after it controls in next October, in next November, or in the southern countries, the opposite in summer, in our summer, that we have to still consider this virus, and we have to do the differential diagnosis. And of course, we have to put the point in the parameters, in the features that are unique from this virus. And here, the artificial intelligence that I am managing, it plays a big role, because we can calculate the probability of the different virus based in the prevalence of the different symptoms. Today, as we will see, when we will see a patient with influenza or rhinitis or rhinovirus, a cold symptoms, if have lymphopenia, we have to highly suspect COVID because it's quite unique. And we have to identify what are the quite unique symptoms for COVID comparing with other virus. Let me go for the diagnostic of the SARS-CoV-2, or also called COVID-19. Fever is quite frequent, 88%, cough, 68%, fatigue, 38%, diarrhea, and vomiting. I don't know, but in practically all the cases, in many of the cases that I have seen around of COVID, they began with abdominal pain, stomach pain, and vomiting and diarrhea. But there's so many, depending the area, but here in Europe, I have seen many cases with that. We have to pay attention, people that begin with abdominal pain, diarrhea, and vomiting. Here, a more extensive article that shows the prevalence. That is ideal when you calculate the probabilities, the artificial intelligence, to see the percentage of all the symptoms and the different degrees of fever. Here we can see the fever is variable. We can see from more than 39 to 37 is variable. The neurological manifestations are important. Many of the patients that get a mild or very, very not really clinical coronavirus, they come back after with an anosmia, and they are not able to taste the food. And that is, this virus is really affecting the central nervous systems, and we can see a lot of neurological manifestations. Now, are not listed here. We have seen a lot of like urticaria-like lesions in the skin. The skin is also showing during the infection of coronavirus. We have to pay attention when we see an urticaria-like reaction. I will mention the transmission incubation. All of you know that it's all the journals, the basic reproductive number, the median incubation period, okay, of the coronavirus. But I want to insist in the droplets. You know, sometimes some people go to the supermarket and they think that keeping 2 meters of distance between you and the person that is close to you in a corridor of a supermarket, you are safe. No, you are not safe. Because when the people is breathing in front of you 2 meters far, you are both walking in this corridor, and the droplets that this person in front of you, if it has coronavirus, you are going to breathe the droplets, because the droplets keep in the air for several hours. For this reason, we have to protect ourselves, and now there is no discussion practically that everybody has to use the mask. And of course, if the particles are in the air, will be impregnated in your hair, in your clothes, in your glasses, in all your body. For the reason, it's recommended after you go to the supermarket, because you have to go anyway, is go change your clothes, clean it, and keep, please, all this, paying attention that these droplets are there for hours, because in the fluid particles, they remain there. Also now there are investigations in Italy that the high polluted areas, also the pollution contains the coronavirus, and that remains and can go with the wind far away. And now they are investigating, because this area in Milan area in Lombardia was very rich, was very contaminated. It's like a valley, not well, and that was maybe one of the reasons that was dispersed the virus in the air. Here, everybody have seen that. I will not insist in this slide, just reminding from the positive cases, 81% are mild, so 14% are severe, and 5% are critical. Here, I will insist here in only one point. The clinical course of COVID is well known, but I will include that the 45% of survivors that are discharged, they have cough. And some of them, they are released after 57 days being in the intensive care, and they have a lung fibrosis. And maybe they are going to have to receive a transplant. For the reason, not only we have to count the deaths, we have to count the disability of many people that are discharged, but they will have dyspnea, they will have difficulties to make exercise, and some of them, they will have dyspnea forever. That is all a very, very important toll that we have to pay for this virus. The fibrosis, the lung fibrosis, that till we don't find any treatment, it's not clear that we are going to, after recover from this, of course, I am going to follow up very carefully the follow-up of this patient, how they recover from that. Okay, it's an important point that the severe lymphopenia was observed until the death in non-survivors, but in others, the lymphopenia count was lowest after the day 7, and they improved during hospitalization. We need to find out how to improve this lymphocyte count. I have a personal theory about the myeloid-derived suppressor cells that are described that decrease the immune system, and some virus and cancer cells is only for research, not for diagnosis, but many cancer studies include the MDSC cells, myeloid-derived suppressors. So we need to investigate that, and we need to work how we can improve immunoboosters. We need to check what we can do to improve after the cytokine storm has finished, after there is no risk, how we can improve these lymphocytes. Okay, here is the multi-organ dysfunction. This is clear. Now there are many fake news that the coronavirus is not a virus, it's a thrombosis. Many people die of thrombosis. Yes, it's true, but the intravascular coagulation, yes, become because the sepsis, bacterial sepsis, viral sepsis. But what is clear too is that multi-organ dysfunction. Recently has been described that there is organ vasculitis, all the vessels in the organs are inflamed, are highly inflamed, and that damage many organs. Now we are investigating why this organ failure, and looks like this virus provoke vasculitis. All the vessels inside the organs are inflamed. And we need to find a treatment for that, for the next outbreak or for the patients that are going to be ill in the next months or weeks. Okay, the radiological features, this is the slide. I am sure this will be recorded and provided, and I am not going to enter, but the important is you can see the X-rays that they have developed also artificial intelligence. Also with an X-ray, you can predict highly the diagnosis of coronavirus because the lung opacity is huge, it's massive. The consolidation, the opacity is, is incredible. Here we can see the bronchogram. Okay, the incidence of other disorders. Which persons are candidates, a part of the age that we know that every year of age increase 10% of the death rate of the coronavirus. Every year you are older, every 10% more of death rate from the child that in this moment are practically non-affected. But it's important which other diseases you have. The chronic pulmonary disease, if you have previous condition, that will make it more severe, more risky, the coronavirus, diabetes, hypertension, chronic renal failure, cardiovascular disorders, cerebrovascular disease, malignancy for sure, hepatitis or liver cirrhosis. The laboratory diagnosis, here I like percentages. 81% of the patients have lymphopenia, and we can review the statistics of other viral infections. We need that. The Bayesian and artificial intelligence need percentage, but this is practically not unique, but quite selective from this virus, the lymphopenia. Okay. 36% of the patients have thrombocytopenia, and I will add that many times when this happens, we need to investigate the D-dimer. We need to investigate the fibrinogen, the D-dimer, to check if this thrombopenia is due to intravascular coagulation. Elevated C-reactive protein, we don't have to forget, C-reactive protein is going how when the liver is working. If we have liver failure or liver inflammation, don't expect that the C-reactive protein is high. For this reason, we need to consider the liver, to consider also the CRP. Elevated levels of lactate dehydrogenase is very important. Elevated levels of creatine kinase. There is a heart and muscle affection with this virus. Here you can see everything in a table that will make maybe for some of you easier. That is the typical pattern, an average of many patients published in the literature from Heshu and others. You see the D-dimer, the fibrinogen, the albumin. Albumin because the low liver production, the transaminases, the C-reactive protein, the low lymphocyte count, the high leukocyte count with neutrophilia normally. Okay. Laboratory diagnosis, also quite unique, is lower oxygenation index than previous SARS. For the reason the oxygen saturation that we can do very easily with a pulse oximeter that you can buy in Amazon, it's very important, the oxygenation. If we don't have, if the patient is in an elder residency, that is easy to do. To do with a pulse oximeter, the oxygenation, that is quite unique from this virus. That is also, you can do the second in the hospitals. We have to monitor, if we can, CRP, and when it's positive, if we have money and the right instrumentation, IL-6 and IL-10, because that is really what makes the difference in the death rate. The cytokine storm, how to avoid it, how to prevent it, that is critical. And we need to monitor when that happens to react, if it's possible, before it happens. Again, the low levels of CD4 cells is very important for this virus. Looks like an AIDS because the CD4 goes very down, but in different than AIDS, also the NK cells goes down and the B cells, as we will see in one study. Here is what happened with the different CRP, procalcitonin, and SAA, the serum amyloid A, that are three markers for infection or sepsis. Not any of them is perfect. And they have, some of the authors propose a combination of the three, in addition of the three, to make much more sensitive to detect the infection or the bacterial infection, because For the organ failure, not all of them, as I said, the CRPs produce it in the liver and are not so sensitive and specific. Combining both of them is one of the ideas I like it. Here is an important point, the diagnosis. Now, many companies are selling kits. Many companies are selling antibodies, but some of the antibodies, believe me, are trash. And really, I think we have to be careful what we use. And I will recommend especially the 3 genes test for polymerase chain reaction, RT-qPCR, because that is the more specific. But even though the best, the RT-qPCR is not perfect. The PCR is very specific, but not very sensitive. We need to combine both. The IgG, IgA, and IgM, IgA in saliva. We need to measure the specific IgA for coronavirus in saliva, and we have to use both. And we cannot say it's a negative if the antibodies are positive and the genes and the PCR is negative. If not, we are going to give false statistics in our country. Here are the specific changes from the SARS-CoV and the actual virus. There are few amino acids that are different for the people that like molecular. We can see the previous SARS and the actual outbreak with some differences in some amino acids. Here is the median time of IgM antibody at 5 days after the infection. 88% of the patients are positive for IgM. IgA specific for virus, 93%. This is the reason we cannot ignore this test. The IgA specific for COVID in saliva. And the IgG was detected on 14 days at 77%. The ideal, if you want to have a 98% of diagnosis, is to combine, as it says here in the 3rd point, the positive detection is significantly increased when combining IgM aside with PCR. Here is how the positivity changed from the time of evolution. Here we can see the evolution of IgM, of IgG, and PCR. For this, depending the day of the evolution, we are going to have to consider the decrease of the antigens. Of course, if the patient is going critical or severe, for sure the PCR will not decrease, will even increase more. And here you can see the percentage of detection. This graph is very nice to see the percentage of detection of the coronavirus. Let me see here. Sorry, here, yeah. That the PCR is 51%. Of course, not the PCR with 3 antigens that have 70%. But in these columns, you can see that the PCR is only 51 till 70. But combining PCR plus IgM, you have 98.6. Many countries that only consider positive the PCR positive are underestimating the number of cases by far a lot. They are reducing the number of positives, maybe 30, 40% lower than really it is in their country. Hematology research studies. Now I am going to a hematology lab. That is my field. Even if I am a clinician, that is my field. The first case that was studied, okay, this was the evolution of one of the first cases in that we can see here how the neutrophils and the leukocytes goes up, and that is going with in correlation with the severe status of the patient. Many patients get super infected with bacteria, and this is a reason in many therapies, including azithromycin as one of the therapies. Of course, if there is no bacteria, there is no need to do azithromycin. Here again is the lymphocytes. How the lymphocytes in the second graph goes down. The third will be the neutrophil lymphocyte ratio. That is one of the parameters proposed by us to follow up these patients. NLR is very sensitive, and as soon as it goes up, we need to consider that the patient is going to go worse, and maybe we can prevent the treatment acting before it's really a sepsis. CRP, again, in the patients with no liver affection is good because can follow up also the severe aspects of this patient. Here, for the people that like to see the plot, this is the patient at the beginning of the study. This is how the parameters and the plots change. We cannot enter in deep on that. We are going to do it after maybe in a workshop. Okay. Here you can see the lymphocytes were 0.37, here 1.82. you can see 0.63, that we can follow up the RDWSD2. And here you can see for this patient in every day what were the clinical status. The summary, we found an increase in the first patient that we analyzed of white blood count, leukocytes, and neutrophils, decrease of lymphocytes, increase of CRP, and increase of neutrophil lymphocyte ratio. That was an experience in Union Hospital in Wuhan that is very interesting because we measure here the cytokines and some of the lymphocytes. Here we can see an evolution of a group of patients, mild and severe, to see the differences. And we can see here that the severe patients have lower white blood cells than the patients that are mild, but the neutrophils were much better because the neutrophils went higher here with an asterisk, was significantly important to differentiate severe from mild patients because that normally shows a superinfection with bacteria. The lymphocytes, again, here is the severe patients and the mild patients. You can see that lymphocytes are very, very important to show that. And I am not going to wait for the day 4 and 6 that is very low. I am going to react when the lymphocytes goes lower than 0.6. When they are going to be 0.5 before the day 4-6, if we act the day 3, for sure is better. Not to wait that they are very low. And that is, for me, the important for the future. What we are going to talk about, what's next. What's next, we need to follow up and to find the best cutoffs for the lymphocyte count to decide to do a therapy before it occurs the cytokine storm, before it occurs the sepsis, etc. The CD3 cells, the total T cells, are significantly different with a very, very big peak at the day 4 and 6. The CD8 are also different in these two groups. The CD4 cells are absolutely critical, but here it's important differentiating that from the 8s. The B cells are also very low, and we need to investigate the reasons for that, why the B cells are also low. Can be the MDSC cells, the myeloid-derived suppressor cells, we will see. But that is something that we need to investigate. That is unique from this virus. NK cells, again, very low, not significant. Also, B cells are not significant, but CD4 cells are significant, very significant. IL-6, the cytokines, as I said, are expensive. Maybe we need to filter with CRP, with procalcitonin, with SAA, but we need to do this test. If we want to make this patient survive, we need to detect when the cytokine storm begin. Because if we can treat it successfully, I will prefer to give immunomodulators, not immunosuppressors, because with immunosuppressors, yes, when you are going to avoid the cytokine storm, we are going to discuss at the end what's next. But yes, we need to react and to detect the cytokine storm. Maybe we need to do this test, easy access, cheaper, produce it. I don't know what the governments can do, but the same that the Indian government did something with the AIDS treatment and with the hepatitis C treatment, I think here we need to do something else to make available these IL-6 and IL-10 that are cheaper and easier to do. IL-2 is also very important. IL-2 is one of the more important immunoboosters, and here it shows a very important peak in the day 4-6 of all these patients. Interferon gamma and tumor necrosis factor, again, are moreover interferon gamma, and that is correlated. There is a treatment that finally is not doing very well, maybe because inhibits the immune system, as a treatment against interferon, to block the interferon. Here you can see that in a graph. Here you said an uninfected individual, you have a moderate COVID, in that you can see the increase of IL-6, IL-10, and tumor necrosis factor. There is a decrease of CD4 cells, but here you can see with the cytokine storm by the macrophages, and the lymphocytes are really, really very low. I like this slide because it shows graphically the COVID replication and the presence of lymphocytes and cytokines. Okay. We have to do a summary. Parameters that have shown a clinical utility are the CD4 lymphocytes, the neutrophils in absolute numbers, and they are high, CD4 low, lymphocytes low. IL-6, IL-10, and IL-2 high are the selective important parameters for the follow-up and diagnosis of these patients. Here you have in a nice study by Liu Jie from Wuhan that they did all the significant statistical parameters that may show a difference between the mild patients and the severe patients. Here we can see with numbers, the values, the average, the interval of confidence, and the p-value showing that is a very good parameter to differentiate severe and mild patients. I selected this article because it shows with numbers that is ideal for artificial intelligence what is really relevant from all the parameters we can do. Okay, the D-dimer, the fibrinogen, the C-reactive ferritin. Patients with high ferritin have very bad prognosis. We need to measure ferritin. The excess of iron is known that have an increase of infections. We have to investigate if patient with hemochromatosis and can have a higher risk to have a severe and critical, and to be careful if the patients that have previously high ferritins, these patients have to be considered high risk. This is just an hypothesis that I am saying here. Don't take it as a scientist evidence, but I will propose to investigate how the hemochromatosis patients respond and how they deal with the coronavirus infections, because all of us, we are going to be in front of this virus. That is really a drama. All of us, in 1 year, 1 year and a half, we are going to be in front of this virus. Doesn't matter how much quarantines, how much things we do, everybody will be in front of this virus. If you have hemochromatosis, be careful, more careful than others. The third evaluation is the evaluation I did. I am going to go fast because I presented before these results, just to show that we were collecting 59 mild people, 16 moderate severe patients, and 19 critical. And here, I will not enter here the definition of the patients. Here, it was my contribution. I selected with my group of research in Mindray 2 groups, that this is not quite frequent in many studies that has been published. We were selecting the patients that were following up, because all these patients have a follow-up of minimum 1 week, but many of them 17, 18 days, that we measured all the CBCs and all the hematological parameters every day. We were looking for patients that become severe from mild, and we collected the samples from the previous days before they become severe. The same for the critical. We collected the results of the patients that after 1 or 2 days, they were critical. And we were trying to see the differences of these patients that have these results previously to the others that will not become severe, that will not become critical. We create the group 4 and 5. And here you can see the groups without the prediction, the group 1, 2, 3, what are the average values and the difference between the groups. The group mild, the group severe, and the group critical. And that you can see the group 2 is the severe and 3 critical. And you can see the average of age. In the critical, the age is higher, also in the severe. The hemoglobin is only lower in the severe. In the group 2, is not significantly different. The hematograms, even if they are in low values, they were very significant when we compare mild from severe and mild from critical. Because hematograms, even in low numbers, are very significant. The lymphocytes are incredible, are very, very important. You can see how different are. RDWSD, it's also very important because 38, 40, 44. But here I have to say that when you study the RDWSD in 1,000 patients before the outbreak, maybe in July 2019, many patients are RDWSD positive for anemia, for many other reasons. For this reason, we cannot use a standard cutoff. We need to see the follow-up. When the patient enters, we need to observe the values of the RDWSD when they are mild at the beginning of the infection, and to see the changes looking the delta check, how the RDWSD moves from the previous values when the patient entered in the hospital and after how much increase, because an increase is also very significant for the outcome of the patient. Neutrophils, NLR, platelets, leukocyte counts. And here, we added here the group 4 and 5 that are the predicted groups. The groups that collect all the samples before that they are now severe and critical, which was one the patient is bad, okay, what you can do is much more difficult. But if you can treat the patients before, that will be the ideal for the future. Here you can see the same with the whisker plots, how the lymphocytes are in the group 1, that are mild, in the group 2, severe, and in the group 3, critical. And how you can see that previous to be severe and previous to be critical are significantly different from the group 1, that are the mild. For this reason, we can use the low lymphocyte count as a factor to predict that the patient entered to be worse. The same for the neutrophils. You can see how the group 1, the mild, have lower values, the group 2 higher, and the group 3 higher. And also here we can see that it's not so useful to predict the group severe, but it's useful to predict the group critical. This is the RDWSD. You can see the group 3 has significantly higher values, and it's very useful to predict when the group 4, before the patient entering from mild to severe, an increase of RDWSD is critical. Now we know that there is an influence between the virus and the hemoglobin. I will not show this article, but there is an article about that. There is something that affects the red cells that is not just the infection, it's an interaction of the virus with the red cells. The platelets goes low only in the critical, and that is very important, and goes lower before it's severe and before it's critical. But this is clear that the platelets only go down, and we have to pay attention even if there are no very low. Here we can see the values, the mean values is 120. We have to pay attention on every a decrease of platelets to predict that something wrong is going to happen. Here the monocyte Z, and that is really my contribution of that to Mindray. Monocyte Z, cell population data, the size of the monocytes can predict the critical phase, and the cytokine storm, the sepsis, and that will have to be used in the future to predict the critical phase, and maybe to initiate a treatment with antibiotics, with any immunomodulators before the patient dies. The monocyte set, you can see how good you can differentiate the group 3 and the group 5, okay? And here the NLR, neutrophil lymphocyte ratio, this is combining the lymphocyte power for diagnosis and the lymphocytes. Sorry, the neutrophils and the lymphocytes, you combine with a factor, and it's very important to differentiate mild from severe. As a summary, the absolute decrease of the lymphocytes, lower than 0.63, is an alarm that the patient is going to have a bad outcome. The absolute neutrophil count, more than 9.2, to have a bad outcome, and in the severe cases, 7.85. The platelet decrease, not very low values, pay attention on that, less than 184. You don't need to wait for thrombopenia. Only when the patient has 200, 300 and goes lower than 184, you need to begin to react. Something wrong is going to happen next days. And RDWSD, here we need to personalize to the patient, but also have to be have in account. The causes for the absolute decrease, virus selective to CD4, MDSC cells that I mentioned before. For the absolute neutrophil, the bacterial overinfection. For the platelet decrease, the sepsis, the intravascular coagulation, that is well known in eclampsia, in many other situations. RDWSD, oxidative stress, inhibit of red cell maturation factor, lack of nutrients, inflammation. And here the more important, because that is for me important, very, very important, prediction of the bad cases. As I said, platelet decrease, lymphocyte decrease, neutrophil increase, and monocyte Z increase. Monocyte Z decrease in the severe cases, here are the cutoffs, okay, less than 889. The neutrophil fluorescence also show a benefit to predict the severe cases. Sorry. And now let me go for my contribution for the future. What now I will talk like a clinician, not as a laboratory specialist. Here, the countries that shows, I cannot say they did wrong. You will see it here. I didn't include Spain and Italy because they were the first in Europe and after China, the first in the world after Korea that were doing very well, Korea, I will mention after the countries that did well, they blocked the case that infected a lot of people in a church, they did very well. But the countries that were not able to react fast, but that I forgive them, even if they have also bad values, Italy and Spain. But the country that for me can do better is because they have the experience of Italy and Spain, and they were not reacting, even if they saw what happening in the countries that they were not unexpected with an outbreak that they don't know which virus is, how it, it was really not predictable. Belgium have 15% of deaths from all the diagnosis cases. That is huge. Remember that we said that the virus only have to have a death rate of 3%. That shows that the country has been collapsed, has been permitted the people to be outside, and that is really terrible. The deaths for 1 million, because Belgium is a small country, is 576, is the highest, okay? And again, the percentage of deaths from all the people that have an outcome, doesn't matter, death of discharge, 40%, that is very high. Sweden, that is an interesting case to learn. Sweden and Norway, they have not very far populations, and Norway did very well, and Sweden did not so well. With 12% of deaths from all the diagnosis cases, a death rate for 1 million people of 213, and a percentage of deaths from all the discharge was 68%. All the people that have outcome, 68% die. That is massive, it's huge. It's one of the worst countries in the world. UK, we know, they ignore it. They said that they want that everybody gets the virus because with that they will be immunized. Okay, 13.57, the Prime Minister infected, the Minister of Health infected, the pregnant lady or the Prime Minister infected is not the best example to follow. The UK idea that was economy is very important, don't close anything, let's immunize the people will be immunized, and after don't show that was the person. They even don't show the data of the percentage of deaths and the percent of discharge. Not available, this data. France, again, they have ignored and they have 18, one of the worst, is the worst number of deaths for diagnosis of coronavirus. 18% of the patients with a positive test for coronavirus have passed. 18% is amazing. The deaths per 1 million, 341, and percentage of deaths from the discharge, 34%. USA, we cannot say many things about the USA. They are not even in the plateau. They are just beginning the infection, but the results don't look very good. The percentage of deaths for diagnosis, because they cannot do yet many diagnoses to all the people, is 5.1, is not very high, but the percentage of deaths for all the people that have an outcome is 32%. And the deaths per 1 million is 158. And now we are going to see some countries that did well. Korea, with deaths per 1 million of 5, the percentage of deaths for discharge 3%. They have no more than the toll you have to pay for that, and that for me is very good. They did very well. India, they did very well with the deaths per 1 million of 0.6, with 3.2% of deaths for every patient diagnosed, and the percentage of deaths for all the patients that have an outcome, 12%. Australia, let me say, sorry for all the countries, I think was the country that did the best, with a percentage of deaths and discharge of 1%, and only 1.19% of deaths for all the diagnosed patients. Australia did react immediately, very strongly, closing everything, and that was good. But now, let me say something. What will happen now? Okay, Australia, they blocked the cases. Yes, it's true, but maybe only 2% of the population has been infected. What happened when they are going now to release all these shops open again, the supermarkets, the malls? What they are going to happen? Because yes, they stopped the first outbreak, but when they are going to open all of that, has the virus disappeared? Or they can control that nobody will enter in Australia. They have to close the country, all the planes, all the goods. We don't know that. In Australia, it's like an island, okay? They can do it better than other countries, but The countries that did well in the first outbreak don't represent that they are free. Are they going now to open everything? Are they going to permit that the people go outside? Because how many people is infected now in India? How many people is infected in Korea? How many people is infected in Australia? That is the questions we need to ask. I will try to answer some of them. The diagnosis criteria, that is very important, that I mentioned before, the positive detection. We need to use that. We need to use both in combination. Don't be playing with the statistics. Don't use only qPCR to show that your country are doing well. Use also IgM and IgA. You need to use that. Don't show lower results than this. And use good tests. 3 antigens for PCR and good IgM, because some of the IgM, IgA, some of the countries are not detecting sensitivities of 30% only. And what's next? Okay, are countries that did well going to go bad if they reopen? The idea is that in 1 year, all the world population will be in contact of the coronavirus. This coronavirus, because there can be another one. Every 1 month, the virus is mutated and can be different virus that will affect maybe, unfortunately, children. And that is something that we need to face, control. If I will be the counselor of any country in the world, I will say, control children. When it will appear the first case of coronavirus with a death, please take measures immediately to put the child in quarantine, because we cannot guarantee that mutations of the virus will affect children. Second, provide all hospital beds with artificial lung ventilator. I think, yes, it's expensive, but I will provide an artificial lung ventilator to all the beds of all the hospitals. We cannot do the same again. We have to, now that the outbreak is going down, before to reopen, be sure that you have enough lung ventilators in all the beds. Do millions of tests to detect who is in risk, who is positive, who has the antibodies. Permit that the people that have antibodies, and you can demonstrate that they are safe to be outside, but be careful with the people that don't have antibodies. They have to be in front of the coronavirus, protect them. Relation, economy, safety. Yes, I know we cannot close the countries for 1 year, because what the people will eat, if all the businesses will go down. And wait till the vaccine is released. Okay, the vaccine will be good for virus, but considering that the virus is mutating, yes, but it's a good thought. Wait for the vaccine. But can India, can Australia wait till the vaccine is released to open the theaters, the cinemas, the football, the baseball? Can we do that? That is the question. What parameters we can use to decide that? I think the contagious number. In Spain and Italy, the contagious number is 1. When we know that can be 3 and even 5. That you have to measure that. Second, number of occupied intensive care beds. I think it's important to control that. When you're, let me take some water, please. I need water. Sorry. Yes. The number of occupied beds. I will begin to release I don't know, the people walking in the street, the people going to supermarkets. When the occupied intensive care beds are 50% only, that you have enough beds to control another outbreak in your country. And to be sure that you have enough protection material available. Remember that in Italy, 10% of the healthcare professionals has been infected, and in Spain, 20%. Before to open everything, be sure that you have a production in your country of material to protect your healthcare professionals. The vaccine, for sure, the vaccine is something that we need to work on that, to be sure that it's safe. Don't go in a hurry. We have to, I know everybody's waiting, every economy cannot resist that, but we cannot release, we need to follow the protocols. We cannot give bleach in your lung to clean the virus in 1 minute. We cannot do crazy things. We need to wait till the vaccine is safe. Key protection measures: distance. Are we going to hack again in the next 1 year, 1.5 years? That is, it's an interesting thought. Predict the severe clinical status and the critical status with the right parameters to avoid deaths. Of course, we are working on that. We are going to publish our results, how to predict and how to decrease the death rate from 3% to 1.5%, to work with the clinicians, to work with therapies can be used 1 or 2 days before the sepsis occurs or the cytokine storm. That is something that we need to work with. Do the right diet. I will talk about that at the end. Moderate exercise, mental positive attitude. My colleague here did a very wonderful talk about that. Follow up the mutations. I said that in children, that is affecting now no children, no teenagers. We need to follow up that and to play measures against that anything happen with these populations that now are free. Practically, there is no children and teenagers affected. And finally, take immunomodulators, immunoboosters. In the nature, there are some immunomodulators, some immunoboosters that we can use. I am expert on that. I am working for that for a long time. Anybody that can want to ask me, I'm not here, but I can talk about that in another talk. And finally, to close my talk, I will talk about the Tibetan Ayurvedic diet. They say the Tibetans, when I was in Dharamsala in Himachal Pradesh, that you are what you eat. And not only what you eat, how you eat. The first thing they teach me is you need to chew 32 times every piece of food you put in your mouth to be sure that it's absolutely broken before entering your stomach, to make sure that your digestion is done in less than 2 hours or 2 hours maximum. Second, don't fill your stomach. Never take 2 parts. If we can divide the stomach in 4 parts, you have to take 2 parts of food, 1 part of water, and have to remain 1 part of air in order that the meal, the food, is well moved, moving, mixing all the acids and so on, to be sure that your digestion is good. Third, keep 3 hours minimum between meals. Don't take anything in between the meals, and don't drink cold things, ice creams, cold water when you are in the middle of the digestion. But also, they divide the diseases in hot and cold, and they consider that the coronavirus is a cold disease. And for a cold disease, they will recommend to take a special food. In that, they recommend some aromatic plants like glandwort, rosemary, thyme, spearmint, oregano, chamomile, ginger, cinnamon, saffron, sesame, and cardamom. Some special vegetables from all of them. Some of them metabolize in hot, some of them metabolize in cold. They will recommend that you take vegetables that metabolize in hot: red onions, spinach, peas, beans, rice, lentils, cucumber, radish, quinoa, bell peppers, tomatoes, scallions, red onions, etc. Finally, the fruits. They will recommend you red fruits, oranges, lemons, pomegranate. Honestly, during the episode of Corona, when I have been traveling, I always take tea with ginger tea with lemon and honey, because to protect me from the virus, having the right food. The animal source, the fish, the lamb, and the eggs, metabolizing hot, almonds, nuts, peanuts, raisins, dates, sunflower seeds, and pumpkin seeds. I cannot enter in deep in the Tibetan medicine. I am a passionate of that after I was in Himachal Pradesh with in the Mensai University. And here we can see a lymphocyte from infectious mononucleosis, an Epstein-Barr virus infection. That was like that. I made the photo, and that is, it was real like that with a form of a heart. This is a T-reactive lymphocyte, a CD8 cytotoxic lymphocyte that is reacting against the Epstein-Barr of this lady, teenager, 17 years old. Have a good day. Thank you.
Yes, Ramon, that was a fantastic talk. You discussed about the pathobiology, you discussed about the transmissibility, you discussed about the detection techniques by both antigen and antibody sensitivity, specificity, and you discussed about the future COVID-19 infections. Wonderful talk. And I open this to discussion, and I request the participants to shoot questions for you.
Thank you, my friend.
Thank you, Ramon, and thank you, sir, Dr. Mishra, for excellent talk. So we do have certain questions here. The first question is from Dr. Sarjan Shah for Dr. Ramon. Is any experience with IL-6 analysis? Is it going to be better than CRP and procalcitonin? And he has one more question is, do you suggest any company making IgA kits?
Excuse me? If yes, you yes, what?
So the first question is, any experience with interleukin 6?
No, at the end, but you say the last question from
okay,
the three.
Can you recommend any
For
company?
IgA kit.
IgA kits.
IgA kit. Okay, that will be, I cannot do it in this conference call, but yes, they can ask, I cannot say publicly which test. I will do commercial things for that. But there are some good qualities for IgG, IgM, for sure, and I know it. But I cannot disclose that in the meeting, okay? That will be an advertising of kits. Okay, but yes, it is. Let me answer the other questions. The other questions were, Suchita?
Is interleukin 6 better than CRP and procalcitonin?
Yeah, interleukin 6, you know, the sedimentation rate is very sensitive, phenospecific. IL-6 is much more, CRP is much better than sedimentation rate, more specific, less sensitive. IL-6 is even more specific and less sensitive, but IL-6 not only is good, IL-6 is also the previous step to epsidin. Is really very much more concrete and much more specific for infection than CRP or sedimentation rate. Sedimentation rate can be high also for a multiple myeloma. PCR can be positive if you do if you run around your house 3 kilometers running, your CRP will be positive. IL-6 is less sensitive, but much more specific than sedimentation rate and CRP. And not only I say that, the statistics show much better results than CRP in the study we did in Wuhan, the Union Hospital. I have shown the data. The STAR shows a significant P less than 0.001. But this not only is my opinion, the fact shows that there are significant difference between IL-6 and CRP. CRP is good, but they propose it when they are using only CRP, procalcitonin, and SAA that you cannot use one of them. You have to use the three. One of them alone is not enough. On chase of that, IL-6 was alone very significant, and you can use it alone. But CRP is very good. I will recommend to use sedimentation rate. If it's positive, do CRP, and if it's positive, do IL-6, because you cannot spend all this money for all the patients. I will do reflex testing to save money and to use a combination of rules, combination of neutrophils, to only select, to do only IL-6 in the patients that maybe also neutrophils are a little higher, lymphocytes are a little lower. I will do reflex testing because we have to be realistic. We don't have all the money of the world to spend in diagnostic tests.
Yeah, thanks, Ramon. That's a good strategy. We do CBC, CRP, and as a reflex, we do the IL-6.
Yes.
The second,
combining maybe neutrophils, combining maybe lymphocytes, etc.
There's a question from Dr. Prajapati. She's asking, what is your experience with symptomatic versus asymptomatic patients?
Okay, the one of the reasons of this virus is so bad is because it can be contagious by asymptomatic patients. And children can bring this virus everywhere, and they, in this moment, with the actual mutation, they don't have the problem. That is the problem. The asymptomatic patients are spreading the virus around, and that is really, you know, they can pass all the controls of the temperature in the airports. Now I have seen today that some countries are opening the university to do the studies and so on, and the exams. You cannot detect them with a temperature. That is the problem of this virus. Some other virus, like influenza, you have symptoms when you are contagious. This virus not. This is one of the reasons of this bad outcome of this outbreak. Previous outbreaks like the MERS and the SARS, the previous SARS was not like that. it was practically all the patients that were infective have symptoms. That was make easier to control this virus. This virus not. The patients are able to contagious in not being absolutely asymptomatic. In addition, when you recover from the disease, you are recovered from the hospital, many patients, the virus come back. Maybe because the severe lymphopenia, the severe B lymphopenia, the severe natural killer lymphopenia that provoke that you are not able to produce enough antibodies. You produce some antibodies, yes, for the detection, for the test, but not to protect yourself, because the severe immunodeficiency caused by this virus. This is the reason we need to work yes or yes or yes in immunoboosters and immunomodulators, but this will be the title or maybe a workstation, a work meeting with experts on that. But we need to find immunomodulators to boost the immune system.
Yeah. So, thanks, Ramon. The next question is, are the hematological parameters different in HIV positive COVID cases?
Can you repeat it?
Are the hematological parameters different in HIV positive COVID cases?
I have not done this study, but by memory, I would say yes. I think HIV is quite specific for CD4. We normally don't see this lymphopenia in other lymphocytes, but yes, this virus have some aspects like the CD4. Let me say this virus is quite selective for the CD4 cells, but not only as HIV. We need to review. I need to review the data. I have not done this study, not this review for this talk, but I have to check. It's a good question to check the NK and the B cells for the HIV. But I don't remember that was so low also NK and B cells. But honestly, in this moment, I cannot answer fully this question. But I think this is much more, have some aspects like HIV, but also affects B and NK. We need to double check all the series of HIV for that.
There is a question from Sanjay Path Lab. They're asking any significance of serum ferritin in diagnosis.
Serum?
Ferritin.
Serum ferritin in diagnosis. No, what has been published is the patients with high ferritin have much more severity, have much more possibility to enter in mild, severe, and critical. They are at risk, and this is a bad prognosis factor. We don't know yet why. I guess that it's only a guess that hemochromatosis can be a very good bad prognosis, a group, but has not been published. We need to investigate now with the artificial intelligence, big data, analyzing. When the countries will liberate the data and we will have a database of maybe 100,000 patients, we have to investigate risk factors. And ferritin is one of them. For any prospective study, I have suggested to do ferritin. If we cannot do for economy, frozen samples to do ferritin afterwards, because ferritin, for me, plays a big role. And the influence of the virus with hemoglobin that has been published also shows that has to be investigated. The values of ferritin are very, very high in COVID patients.
Ramon, we do have few more questions. Can we continue for 5 more minutes?
Yeah.
We do have few more questions. Can we continue for 5 more minutes?
Absolutely.
Okay. So there's a question from Dr. Parimal. What tests should be done for non-symptomatic or asymptomatic patients? What tests are recommended?
Okay, the first one we know that is positive.
Asymptomatic? No, we don't know.
We don't know.
They're not.
I think for a patient that are a CBC can be enough. A CBC can be enough to exclude any affection, but I think we need to combine. If we have to do a CBC plus CRP, maybe CBC, CRP, and to do the IgM, IgG, and PCR. I think that will be, if I have money enough, I will do not only the RT-qPCR, because I would like to have a previous result of the future complications. I will use the opportunity that I am doing RT-qPCR and IgG, IgM, that I need to take blood to to all the screenings as CBC.
So there's a last question we take from our YouTube live audience. So there's a question: which tests are important for emergency surgeries if patient come directly to tertiary center?
If they go to the center, I have answered this question. Let me share again. I think the important are the lymphocytes, the neutrophils, the monocyte Z, the platelets, let me review here because it's in one of these slides. Let me review here. Yeah, RDWSD, it'd be important. Platelets, neutrophils, lymphocytes are really important. If anything is wrong or sedimentation rate, I will recommend to do CRP. CRP will be also important to follow up these patients. Yeah, I think a CBC with a good instrument like ours that have cell population data can be good, and pay attention in the monocyte Z and do CRP at the minimum problem. And of course, do the RT-qPCR and the immunoglobulins, the IgA and IgM.
I request Dr. Mishra to give the closing remark, please, sir. Thank you, Sujita. It has been a great interaction. Good questions to Raman. I have my last question to Raman. Are you ready, Raman?
Yes, always.
If I could ask you, do you find enough morphological changes in the neutrophils, in the lymphocytes, and the monocytes, like other viral infections in COVID-19 infection as well?
Yeah.
Other than the numbers and the counts and numbers and the size.
You know, I am investigating that. Just recently, I had received yesterday one article in China, and there is another article from Dr. Gina Zini that it's published that are very, very nice. Well, I am investigating now the morphology and the correlation of the morphology. What I will pay attention is when the monocytes become bigger. The monocytes bigger in the blood smear can predict the cytokine storm. For this reason,
the mean monocyte volume is higher.
The monocyte Z, the monocyte Z in Mindray instruments, it's an important parameter. Every technology is different. Can be the monocyte Z, but not other size of volume. But the monocyte Z for me can be a very important parameter to automate and to make a flag in these days that will say monocyte macrocytosis as a parameter, as a flag. Also, I will pay attention on the delta check of the platelets. I will pay attention of the lymphocyte decrease. Any delta of lymphocyte decrease can be absolutely important. Any delta of neutrophils, I will pay attention on that. And maybe not to apply to all the patients, but to apply that the patients that have COVID positive to do like reflex testing to pay attention in the patients that have any risk. You cannot see all these parameters to all the patients, but maybe have a reflex testing or a selection of patients in that we are going to ask the laboratory technicians to write down in the report these parameters for us, but only when they are they have a previous diagnosis of a previous suspicious of COVID.
So one last question, Raman. One last question.
Tell me.
Why is there a hypercoagulable state in COVID-19 infection?
For sure, because the bacteria. There is clear that the neutrophilia can show a bacterial infection, you know. It's a super infection. It's normally, but I never seen in a severe virus, because the AIDS, you need a lot of months to have a low CD4. Here, in only few days, you have extremely low CD4. That never happens in AIDS, you know. And also the very low CD19. That shows that this virus is growing in these lymphocytes. It's using these lymphocytes to replicate itself. And this is the reason they disappear. they are so low, and for sure you don't have B lymphocytes, you don't have NK lymphocytes, you don't have CD4. Of course, bacteria, happy, we can grow here like in an agar plate. You know, it's absolutely fantastic for them because they have a severe immunodeficiency, like rarely you see today in HIV, because they need a lot of months to get these low values. The CD4 arrives to 25, not 400, no, 25, 30, very extremely low values. And of course, the bacteria comes, the bacteria activate the coagulation because the bacteria have this factor 7 activation. You know, they initiate the coagulation, the fibrinogen, the fibrin, the D-dimer. It begins because the bacteria have this thromboplastic effect, activating the coagulation. Some people say they die of thrombosis. Yes, for sure. But before that, they have a growth of bacteria, and that is what is difficult. How you will cure a patient without lymphocytes, without any lymphocyte, only with antibiotics is so clear in medicine, you cannot cure a patient. You need the support of your own immune system. Only with antibiotics, you are not going to do anything.
Thank you. Thank you, Ramon, for that
the way to increase the immune system, to immunomodulate, to avoid the cytokine storm, to avoid this decrease of lymphocytes. We need to investigate that, and I have some proposals for that.
Thank you very much, Ramon. And I think we profusely thank you for giving a great insight into this subject. And I'm sure still the science is evolving, and more days pass by, we'll get more information about the biology of the disease. Thank you very much. Thank you so much.
You're welcome. Have a good afternoon.
Now I hand it over to the Mindray person.
Thank you, sir. Thank you, Dr. Mishra. Thank you, Ramon, and thank you, Dr. Reddy, for excellent sessions. And we look forward to coming out of the situation the very positive approach. And see you and meeting you personally soon. And we all should be happy, healthy, be safe to all. Thank you again.
Yes, same to all of you. Thank you.
Thank you so much. Just to remind to all of people who are visiting or seeing the session on the Zoom app, we are also available on the YouTube channel. So recording of this session will also be put up on the Mindray India page. So feel free to take this reference, go back to the Mindray India YouTube page and look at the sessions again. Thank you, and thank you. Have a great day ahead. Thank you.